So lots of sulfur drugs were synthesized and began to be used clinically. However, resistance soon crept into sulfur drugs. And because of this resistance, and when the resistance began to be apparent widely, then penicillin came into the picture. And so therefore, the use of sulfur drugs in the clinic gradually declined. But still, sulfur drugs are now emerging as good therapeutic agents, especially for infections due to immunosuppression. Okay. So especially in patients with AIDS, where there are opportunistic infections. So sulfur drugs are now having a resurgence. So the clinically used sulfur drugs can be classified based on classification of sulfur drugs, the currently used clinical drugs. They can be classified based on the duration of action, as well as the site of action. Okay, so they're usually classified according to the duration of action and site of action. So it's rather a hybrid scheme of classifying the clinically used drugs. So based on these criteria, sulfur drugs are classified as short or medium acting agents. Okay. So if something is short or medium, then we have the long acting sulfonamides. And if the action is limited to one site, then in this case we have sulfonamides. Limited to the GIT. Meaning they've got action only on the GIT. So if you give something orally and it has got effect only on the GIT, it means it is not absorbed. So sulfonamides having action in the GIT are sulfonamides which are having very low solubility. Okay? So that could be a generalization. Another site that these drugs are used are at local sites, like for burns. So those agents, we classify them as topical sulfonamides. Okay. So based on the duration of action and the site of action, we classify sulfonamide drugs as this, as short acting or medium acting, long acting, and sulfonamides limited to the GIT, and topical sulfonamides. Okay, let's look at them in some detail. Okay, so let's look at the first one. Let's look at short or medium acting agents. Okay, so the clinically used, currently clinically used drugs for which belong to this category include sulfix, oxazole, okay, and sulfafurazole, and the prototype drug that we have discussed previously. Yes, sulfonamide. Okay. So these drugs are used to treat urinary tract infections. Okay, currently they are used to treat urinary tract infections. There is another drug that belongs to this class, which is sulfonamide. Methoxazole. Okay. The importance of this drug is that it is often given combined with trimethoprim. Okay, so why it is combined? We will be discussing that in just a moment. Okay. So this drug is combined with trimethoprim, and it is less soluble than sulfoxazole. Okay, so that's a small point that we need to remember. And then there is this drug, and this drug is sulfadiazine. Okay. So this drug is also short acting, and when we classify them along with these drugs, we are assuming that it is given per oral. Okay, so this drug is also used topically. So it's combined with silver to form Silver Sulfadiazine, and that is used topically for the treatment of burns. We'll be visiting that point in a bit, but to remember that sulfadiazine is given both orally and it can also be administered topically. Okay, so that could be an example of a sulfa drug that's given both, which has got action both orally as well as topically, especially when it is combined with silver. So silver sulfadiazine is used topically, and sulfadiazine can be given per oral. It can be given orally. Okay. So when it is given per oral, we need to remember that it exhibits low protein binding, and it has got low solubility, but it is highly active. Okay, so it's active in the blood, so it's active against blood pathogens, and it can easily cross the cerebrospinal fluid, meaning it can cross the blood-brain barrier and can enter into the cerebrospinal fluid, so it can be used for CNS infections as well as bacteria growing in the blood. So, yeah, so we need to remember that point about this. Okay. Let's take up the next classification. The next classification is long-acting sulfonamides. So what are long-acting sulfonamides? Okay. So long-acting sulfonamides, from the name itself, they are long-acting. Okay, so meaning they've got a T-half that ranges from about 100 to 230 hours. Okay, so that is quite long-acting. Okay, so the peak level, so meaning the peak plasma level, is seen about 2.5 to 6 hours after per oral administration, and the usual dose is about 500 milligram. So if one administers 500 milligram orally, then this drug would attain peak levels in 2.5 to 6 hours, and it would have a T-half which is between 100 and 230 degree Celsius. I mean 100 and 230 hours. Okay, between 100 and 230 hours. Okay, So what's the clinically used important drug? The important drug is sulfadoxine. Okay. So this drug, so what could be the use? Why do we need a drug with a long duration of action? Well, in certain conditions. For example, it is combined with pyrimethamine, and this combination this combination is used for the prophylaxis. So what is prophylaxis? Yes, prophylaxis means it is given as a preventive measure. Okay, it's used for the prophylaxis of malaria. Okay, so that is the fever caused by malarial parasite, which is transmitted by mosquitoes. Okay, so it's used. The combination is used in the prophylaxis of malaria in pregnancy. Is this combination used in all the countries? No, it's used only in certain countries, especially in the tropics. Okay. So that's the clinically used drug that we need to remember, sulfadoxine, and to remember that it is combined with pyrimethamine. Let's now look at drugs which are limited to their action in the GIT. Okay? So the drug here that's important for us to remember is sulfasalazine. Okay? So this drug is used to treat ulcerative colitis. Okay? So itis meaning inflammation, coli meaning the colon, and ulcerative means there is a break in the mucosa. Okay? So certain conditions where there is a break in the mucosa of the intestine, then that leads to an inflammatory condition called ulcerative colitis, and for that this drug is given. So to remember that we need to remember that this drug has got action only in the GIT. So it's not very soluble. It does not get absorbed to any significant level. Okay. So how does it cause its activity? We'll be discussing later that it is degraded by the intestinal microflora to an anti-inflammatory moiety. Okay, and that anti-inflammatory moiety is what is responsible for the anti-inflammatory effect. Okay, so we'll be studying that when we talk about the absorption of this drug. Okay, okay. So just to remember that this drug it gets degraded by the intestinal flora, the normal intestinal flora, and it gets converted to an anti-inflammatory component, and that component is basically used having an effect in this inflammatory condition. Okay, so yeah, we'll talk about this again. So then there are topically used drugs. So what are topically used? Topically means it's used locally, okay, maybe on the skin. And the important drug that has been used historically is a drug called mafenide acetate. Okay. So this drug was used initially, but this drug had a problem. It had carbonic anhydrase activity, and that could lead to systemic acidosis. Okay, so when we mean systemic, we mean metabolic. Okay, so it had got this important adverse effect. Okay. It used to cause systemic acidosis. So therefore, a newer drug came into the picture, and that drug is what is now commonly found in almost all the first aid kits which are available. Okay, and the drug is silver sulfadiazine. Okay, so silver sulfadiazine is the one that is currently used topically. Okay, so what's the advantage of this? It has got fever side effects. Okay, so what is a side effect? Okay, a side effect is some reaction that is found in the therapeutic dose. Okay, and it's found in almost all the patients to whom it's administered. Okay. So the point to remember here again is that here sulfadiazine basically acts as a vehicle. The sulfadiazine moiety acts as a vehicle for the delivery of silver ions. Okay. It is the silver ions that have got antibacterial activity. Okay, the sulfadiazine molecule also has antibacterial activity, but when it is combined with silver, then the activity of silver kind of predominates. So that is not to say that sulfadiazine does not have activity, but to remember that silver ions are responsible for the majority, the lion's share of the antibacterial activity, if you will. Okay. So this is used. So why do we use this? So we use this for burns. It's used for burns. Used in the treatment of burns. Okay. So why burns? Because we know that skin is a barrier. It prevents the microorganisms from entering into the systemic circulation. But when you have a burn, you lose the skin, layers of the skin, then you become amenable to attack by microorganisms, some of which may be pathogenic. Okay, so therefore it's given. It is applied topically to kill the bacteria which may have landed already or which are about to land on the burnt area. Okay. So the other drug that is used topically is sulfacetamide. Sodium solution. So sulfacetamide, it's not very soluble, but if you combine it with a sodium salt, it becomes soluble. And if it is soluble, you can easily make a solution. And this solution is used for the treatment of conjunctivitis. Again, an inflammation of the conjunctiva, which is the membrane in the eye. Okay. This solution could also be used for the treatment of, can also be used for the treatment of skin conditions like acne or maybe rosacea. Or like seborrheic dermatitis. So this drug would, so we said it's used for inflammation as well as the treatment. So acne, some microorganisms in some types of acne, you have got um, certain microorganisms which infect and cause acne, like Propionibacterium acnes. Okay, so yeah, so what we understand is it's used for inflammation as well as antibacterial activity. So it has got it is an, let's write it down here, it's an anti-inflammatory and antibacterial agent. And what's the example we gave? We said that acne, so sometimes acne, there is an inflammation, and then if we do a bacterial culture, we find that it might be inhabited by Propionibacterium acnes. Okay. Okay. Right. So let's recap what we were discussing just now. We're looking at the classification of sulfonamides, and we said that they're classified based on the duration of action and the site of action. And based on the duration of action, depending, sometimes these agents are classified together, the agents which are having short acting as well as medium acting. And the drugs are sulfoxazole, sulfafurazole, sulfanilamide. And sulfanilamide, we say that's the, let's highlight it here, it's the prototype sulfonamide. Okay. And then there is this drug sulfamethoxazole, and that we said it's important because it's combined with trimethoprim. It's also used for UTI. And sulfadiazine, it's administered per orally in this case, and it has got excellent activity against pathogens in the blood, and it easily crosses the blood-brain barrier. Okay? So it crosses the blood-brain barrier to reach the cerebrospinal fluid. Then we have long-acting sulfonamides, and we said the representative example is sulfadoxine, which is used clinically. And to remember that it is administered in combination with pyrimethamine, and it's used for the prophylaxis of malaria. And then we said there are certain sulfonamides which are not very soluble, since they are not very soluble, they are not absorbed. And if they are not absorbed, they can be used for the local infections of the gastrointestinal tract. And one of the local infections is ulcerative colitis. And we said the mechanism of action is that this sulfasalazine is acted upon by microbial pathogens, and it converts it into an anti-inflammatory compound, and that anti-inflammatory compound is responsible for its pharmacological action against ulcerative colitis. And then we talked about topical sulfonamides, and we said the first agent that was used was mafenide acetate, but it has got systemic effects, like it can cause metabolic acidosis, and therefore that led to newer agents like silver sulfadiazine being developed. And this drug, sulfadiazine itself, acts as a vehicle for the delivery of the silver ions, and it's the silver ions that have predominant antibacterial activity. Okay? And then there is this drug sulfacetamide, which has got anti-inflammatory and antibacterial activity, making it an effective agent for the treatment of conjunctivitis, acne, rosacea, and seborrheic dermatitis. So that is the clinically, currently the drugs, that's the classification of the drugs which are used currently, which belong to this class of sulfonamides. Okay. Let's now throw some light on the pharmacokinetics of this drug. this class of drugs. Okay. So, okay, so in pharmacokinetics, we're going to look at the ADME of the drug. Okay, so we're going to talk about the ADME. So, what does ADME mean? Absorption, distribution, metabolism, and elimination or excretion. Okay. So let's look at absorption first. Okay, let's look at absorption. Okay. So let's take the prototype drug. And what's the prototype drug? Right. Okay. This drug is usually absorbed from the GIT. Okay, so newer agents have more solubility, but in general they are absorbed from the GIT. So there is, when we say the GIT, there is negligible absorption from the stomach. Okay, so it's basically from the intestine. Okay. And there are some drugs like sulfapyridine and sulfathiazole. They are poorly absorbed. Okay. But if we look at this, both these drugs, sulfathiazole is better absorbed than sulfapyridine. And then there are certain non-oral drugs. Okay. So what are we talking about? We're telling that it is absorbed from the GIT, meaning it can be given per oral, so we can administer it orally. And when we administer it orally, they are mostly absorbed from the intestine, and they show negligible absorption from the stomach. But there are certain drugs which are poorly absorbed, and the examples are sulfapyridine and sulfathiazole. And then there are non-oral drugs we saw in the classification. Okay, so if we give them orally, they are not absorbed. Okay, so they don't have systemic effects. So when we say non-oral drugs, we mean to say that there is no or negligible systemic effect, meaning they are not absorbed into the blood. And what was the example that we gave? You're right, sulfasalazine. Okay. And we said that this drug gets metabolized by the intestinal bacteria. So it is metabolized by the endogenous flora, so which means the endogenous bacteria which reside in our intestine, and it converts sulfasalazine to sulfapyridine, and 5-acetyl salicylic acid. Okay? And this moiety has got anti-inflammatory effect. Okay? And sulfapyridine will not be absorbed. It's poorly absorbed. It will remain in the intestine. It has got antibacterial activity as well. but the anti-inflammatory activity is due to 5-acetyl salicylic acid. So what was this given for? It was given for inflammatory bowel disease. Okay, so inflammatory colitis. Then we talked about another drug which is not absorbed orally, which was the drug, very good, sulfacetamide. Okay, sulfacetamide, and we said it's given for topically for the treatment of, so it's given topically for the treatment of conjunctivitis. Okay. Then we talked about another drug that is given topically, which was that Silver Sulfadiazine. Okay, and that was given for the treatment of burns. Okay, so but these are not given orally. Okay, so these have got these are non-oral drugs. So sulfa drugs, the prototype drug is sulfanilamide. It is absorbed from the GIT, but other sulfonamides, they don't have oral activity, and the examples are the non-oral drugs. Okay. So when we give it per orally, it is seen that the peak effect is seen in about 2 to 4 hours. Okay, so after 24 hours, 50% of the blood concentration is seen in the CSF. Okay. So if what is CSF? Cerebrospinal fluid. Okay, so 50% of the blood concentration is seen in the CSF after 24 hours. So it will take time for it to act against the agents which are present in the CNS. Okay. Yeah, so let's come to distribution. So we talked about absorption, and now let's talk about distribution of the drug. So what does distribution mean? So after the drug is given orally, so after per oral or intravenous absorption, after it reaches the blood, in the blood it has got options. It may be found as a free drug, or it may be combined with plasma proteins. And this is transported throughout the tissues, and this process is what we call distribution. Okay, so after administration, after it reaches the blood, what happens to the drug, which are the tissues to which they get transported, and do they remain in those tissues? That is our concern when we discuss the distribution. Okay, so let's take an example of a drug. The drug that we can take is sulfadiazine. Okay, let's look at the use of this drug. So sulfadiazine is used for the treatment of UTI. What is UTI? Urinary tract infection. It is given for acute otitis. So what is otitis? It is again inflammation of the ear. Inflammation of the ear. Okay. It's given for influenza. What is influenza? Okay, it's basically a disease caused by virus. Okay, and it's given for meningitis. Okay, what is meningitis? It is the inflammation of the meninges. So what are meninges? Meninges are the the coverings of the brain. What are the meninges? Yes, dura mater, arachnoid, pia mater. Okay, so those are the meninges. So it's given for these conditions. Okay. So what do we understand? We understand that it is found in the urinary secretion. Okay, it's found in the urine. It is found in the fluid in the ear. It's found in the pulmonary system. It is found in the CNS. Okay, so what can we infer from this? That sulfur drugs are distributed into almost all tissues. Okay, so they are seen in the CNS, they are seen in the pulmonary fluid, they are seen in the fluid in the ear, they are seen in the secretions of the kidney in the urine. Okay, so they are distributed throughout the tissues of the body. Okay. So the next point is that it is the free drug that has got activity. Okay, the free drug is responsible for the activity of the drug, and when it is transported in combination with plasma proteins, it kind of acts like a reservoir. Okay, so that's the point that we are going to talk next. We are going to say that the sulfur drugs are they are bound to plasma proteins, and that way they get transported. So they are highly protein bound. So that's the next point. So in distribution, we say that if we take this as again as a prototype drug, then we say that it is protein bound. Okay, and in that combined state, it is transported throughout the body, and this protein bound form is in equilibrium with the free drug. Okay, and it is the free drug that is responsible for the activity. Okay, so as free drug is consumed, more and more protein bound drug will become free drug, and then they will exert activity. As a result, sulfadiazine has got a long duration of, it has got its duration of action ranges from medium to long acting. In this case, it would be medium acting. Okay. Okay, so they are protein bound. Okay. All right. So if they are protein bound, then it is likely that if you give another drug which was previously protein bound, so let's say there is a patient here, and this patient was initially on warfarin. Okay, so the patient was being given warfarin, and this warfarin, what does it do? When you give warfarin, it is also highly protein bound. Okay, so it forms a combination with plasma protein. Okay, and which is the most important plasma protein? Say albumin. Okay, and it combines with this plasma protein, warfarin, to form a drug protein complex. Okay, so this is a drug protein complex, and this complex is in equilibrium with free warfarin, and this free warfarin has got anticoagulant activity. Okay. So now to this patient who is on warfarin, we administer to this patient, we are going to give sulfadiazine. Okay, so to the patient on warfarin, we are going to give sulfadiazine. So what's going to happen is the sulfadiazine will release warfarin from the binding site, and it will take the place of warfarin. Okay. So what's going to happen is sulfadiazine plasma protein complex will be formed. This will be formed, okay, and it will displace warfarin. Okay, meaning now in this patient's body there is free warfarin. So there will be increased concentration of free warfarin. Okay, and that can cause increased anticoagulant effect. And if there is increased anticoagulant effect, the patient may have spontaneous bleeding from the jaws, okay, or mucosal membranes in the intestine and so on. Okay, so the consequence of being protein bound is that protein bound drugs may show interactions like this. So interactions in this case with warfarin, so a drug interaction like this, displacement drug reaction interactions. Okay, so this is called, so they show, what do they show? They show displacement drug interactions. Okay, with what kind of drugs? Highly protein bound drugs like warfarin, or for example with warfarin, NSAIDs. Okay, what are NSAIDs? Non-steroidal anti-inflammatory drugs, or sulfonamides, okay, which are anti-diabetic drugs. So if sulfonylurea is displaced, like warfarin is displaced, then the patient's blood sugar will go down, and sometimes precipitously, and it wouldn't be very pleasant for the patient. Okay, it has got important consequence too. For example, sulfur drugs are contraindicated in infants and in pregnant women nearing term. Okay, so it's contraindicated in pregnant women and infants. Why? Because normally we have RBC breaking down into bilirubin. This bilirubin is transported along with proteins, bound to proteins. Okay, plasma proteins. Then it is taken to the liver, and then this plasma protein bound bilirubin. Okay, so bilirubin forms a complex with plasma protein, and that is in equilibrium with free bilirubin, and free bilirubin is excreted through the urine, whereas the bound form goes into the liver and through the hepatoportal system. Okay, hepatoportal system, it goes into the intestine, and it is excreted through the stool. Okay, so this is how normally bilirubin is removed from the body. So there are no specific transport systems for bilirubin in the body. Okay, so they use this mechanism. Now, if sulfonamides are given to pregnant women, what's going to happen is bilirubin gets displaced, meaning there will be lots of free bilirubin. And this lots of free bilirubin, they have got a propensity to deposit on the brain, on the white matter. Okay, they go and deposit in the brain, and that can lead to developmental deficits in the either in the fetus or the newborn child. Okay, So there can be delayed development of the brain. So that can have very, very serious consequences. Okay. So when that happens, we call it hyperbilirubinemia. Hyperbilirubinemia, meaning increased concentration of free bilirubin in the blood, and the consequence is it can get deposited in the brain, and that can cause something called Kernicterus. Okay, and that, what is the consequence of Kernicterus? There can be developmental abnormalities in the brain. Okay. Again, that is not a good outcome. So therefore, it is contraindicated. It is usually not prescribed to pregnant women or infants. Okay. So those are the most important things when we discuss the distribution of sulfonamides. Okay. So let's now discuss the metabolism part of it. Yeah. Let's talk about metabolism of sulfonamides. Okay. So metabolism for sulfonamides happen in the liver. Okay. We need to remember it happens by oxidation and acetylation. Okay. So oxidation is phase 1 reaction, and acetylation is phase 2. Okay. So when we studied metabolism, we have learned about this. Okay. So let's try to explain this with the chemical structure. Okay. It makes the discussion a bit easier to explain logically. Okay. So let's write the general formula of sulfonamides. Okay, so this is a general formula of sulfonamide. So let's say this is sulfonamide, and it undergoes metabolism, which is the site we talked about, liver. Okay, and what are the two main reactions happening in the liver? Oxidation and acetylation. So let's write here, it undergoes N-oxidation. Okay. The N-oxidated metabolite is combined with glutathione, okay, to form glutathionyl sulfonamide, and the other part undergoes acetylation, and both these metabolites are excreted through the kidney. Okay. Since we are talking about excretion as well, so let's draw a diagram here, and then we are also talking about metabolism and elimination together. Okay, so yeah, so it's excreted through the kidney. Okay, now the body has got only a very finite store of glutathione. So if the patient has consumed lots of sulfonamide and all the glutathione has been used, what is left is the N-oxidation product. So what happens is this, when the glutathione, so let's write it down here. When glutathione. Okay, that's right. Available glutathione is exhausted. Okay, meaning the store of glutathione in the body completely is consumed. Then what happens? This N-oxidated metabolite combines with the carrier protein, which can be albumin, and this combination acts as a hapten. What is an hapten? A hapten is something that can provoke an immune response. So once this hapten is produced, this hapten becomes like it's an antigen. Okay, so the body tries to produce antibody against the combination of the N-oxidated metabolite and the protein. Okay, so that antibodies then become responsible for allergy. Okay, responsible for allergy. Okay, so the point to remember here is all sulfa containing drugs, they have got the potential to provoke the allergic response. Okay. Okay. So in this case, it is the N-oxidated product that is responsible for the allergy. Okay. And acetylated product. So both these products, after it combines with glutathione and the acetylated metabolite, they are excreted through the kidney. So what's the significance of this diagram that we've drawn here? Okay, so we need to remember that it is metabolized by the liver. Now, suppose there is a patient who has got problem with the liver. Maybe the patient is an alcoholic, has got hepatitis. Okay, so maybe it's alcoholic hepatitis or hepatitis caused by hepatitis B virus. Okay, so in either case, this drug might not be the best choice to be given in such a patient. Okay, because the liver function is already compromised. If the liver function is compromised, what's going to happen is the excretory pathway may not be activated. As a result, the drug will accumulate in the body, and that can have unintended consequences. Or the same reasoning applies if the patient has got a kidney problem. Okay, these metabolites are excreted through the kidney. So if the patient is a patient with kidney failure, then the drug won't be excreted. As a result, it will accumulate in the body. Either the drug or the metabolite will accumulate in the body, and that may have unintended consequences. Okay, so we said so the oxidation pathway, it is a phase 1 pathway, and acetylation is a phase 2 pathway. Okay, so what are the other examples of phase 1 reactions? Right, so let's write it down here so that we can recall. Phase 1, we talked about oxidation, reduction, hydrolysis. These are all phase 1 reactions. What about phase 2? Examples? Right, phase 2 is when something gets conjugated. Okay, so we have glucuronidation, acetylation, sulfation. Okay, so those are all examples of phase 2. So now we know why we have talked about phase 1 being an oxidation being a phase 1 process, and acetylation being a phase 2 process. Okay. Okay. The other thing to remember here is the acetylated metabolite. The acetylated metabolite is not very water soluble. Okay, is not very water soluble. So as a consequence, it can precipitate in the acidic environment of the urine. Okay. So if it precipitates, what can happen? It can cause crystalluria. Okay, what is crystalluria? Basically kidney stones. Okay. So one of the adverse effect is that it may cause crystalluria. The reason being, it is not water soluble in the acidic environment. So how can we advise the patient to prevent this? We can ask the patient to consume water. Okay. So we can advise the patient to consume water so that there is less crystalluria. Or if it becomes pathogenic and lots of crystals are deposited, then medically what can we do? We could give maybe sodium bicarbonate. Okay. Okay, it can alkalinize the urine. So if it alkalinizes the urine, then this salt will get it will become soluble in the alkaline environment, and then it can be removed from the body. So that is a medical treatment, but then not for all patients. It depends on whether the patient is a candidate fit for surgery. Okay, but that's an option. So anyway, so this could be what we counsel the patients on. Okay, so if you consume this drug, you should take lots of water, and if there is persistence of, if you've got symptoms of kidney stones, you should visit a clinician who could suggest further management. Okay, a specialist. So it will be a surgical problem. Okay, kidney stone is a surgical problem. So they should meet who? The specialist. Surgical specialty is urologist. Okay. So anyway, so that's just an aside. But the point being that the patient should be advised to consume water. Okay, and the sulfur moiety can cause allergy. Okay, not only this kind of allergy, it can also cause photosensitivity reactions. Okay, so that would be the adverse effects. So when we discuss the adverse effects of this drug, we'll be coming to that point again. Okay, so there is one more consequence of the metabolism happening in the liver. So in the liver, there is the enzyme cytochrome P450. Okay, so if the metabolism happens through cytochrome P450, there might be drugs which interfere with cytochrome P450. They may be either cytochrome P50 enhancers or inhibitors. So those drugs can may have a potential drug interaction with sulfonamides. Okay, so we need to keep that in mind as well. Okay, so we have covered the pharmacokinetics of sulfonamides here.